Hello students, we will discuss another important perineal condition. Just see what this condition is. See that? See that? Here you can see what this condition is. There is a swelling, patient may be having a pain, there may be induration, some necrotic area is there in the skin area. So what is this condition is? It is anorectal, actually perianal, actually ischiorectal abscess, specific ischiorectal abscess, right-sided here, right-sided here. This is the normal side, this is the pathological side. So this is ischiorectal abscess. What are the features? It's a localized painful swelling in the perianal ischiorectal fossa, ischiorectal area here. Tenderness, browny induration, redness. Fluctuation may not be elicited here because they're deep in the cavity. You know that ischiorectal fossa, its borders, medially rectum, laterally, fat is there, then above, Kalkos canal is there, neurovascular bundle is there, and below, in the deeper plane, lower part, skin and subcutaneous tissue is there with the fat. So, anatomy is very, very important. Surgical anatomy, ischiorectal fossa is a very common short note asked along with the briefly about the ischiorectal abscess as such a very common entity and very painful, severely painful. Patient will have fever, chills, rigors, often bilateral, both sides. It may communicate both sides here. So becomes horseshoe abscess, both sides, like this, both buttock area. So it is horseshoe abscess. Like this, it's connected, it will be connected like this. Points to remember are surgical anatomy should be understood well. Rectal examination should be done. You should do the PR in this patient so that rectal wall, other area, there is a focus feature in is there. Inner rectal areas are in normal or abnormal. Antibiotics should be started, should be drained earliest in lithotomy position under spinal anesthesia. We can train under local anesthesia, but usually under spinal anesthesia or general anesthesia is ideal. Cruciate incision like this. Cruciate incision like this. This is the cruciate incision. It's the incision which you place like this, not one incision, like this. With the skin edge you have to cut so that it will not seal automatically. It should allow it to granulate from the deeper plane. So you have to put a pack, you have to take a good wash, send the pus for culture, then regular dressing, allow it to heal from the deeper plane to which averts it from the fistula. Draining pus, adequate wash, cavity should be packed. High chances of fistula formation. You have to always tell that there's a very high chance of fistula formation, which eventually requires a proper addressing like any other fistula in you know. So there is the point which you have to remember, very commonly asked, viva, short note, and management wise day-to-day surgical OP will come across this condition, that is ischiorectal abscess. So read my clinical methods in surgery with video examination, read my surgical manual, it details everything including ischiorectal abscess and other things with illustrations, photos, footnote, clinical case scenarios and MCQs, and SRB surgical operations, both 2 volumes with the detailed minor procedure to major procedure, procedure technical aspect, and tissue approximation, hand atlas with video backup, and my DigiNow lectures, everything is covered, surgery, entire topic as far as CBM syllabus is considered, and that through JP publishers, including specialties, operative surgery, X-rays, specimens, instruments, and so on. So students, I hope you understood ischiorectal abscess very well. Thank you very much.